Yeah, I really like that last comment, David, because it's clear that how, it's like us deciding for older people what's good for them and getting input from them to understand what they want is going to be very important. And I think just to summarize before I open it up to input from and questions from the audience, it seems to me that we need to be coming up with some measures of what successful aging is for several reasons. One is for healthcare providers to understand when people are going to be, who are the vulnerable people or at-risk people, and when would be the time for intervention. And then from the point of view of government, we need those to understand how we can come up with recommendations. What do we need to come up with recommendations for older people? Because if we don't have any targets in terms of intervention, we're not going to be able to recommend different nutritional intakes or other lifestyle changes. And then from the point of view of food industry, they would need to understand what is their target in terms of developing food for a healthier population, whether it's whole food or supplement or what have you. So because of that, it becomes important for us to have some tangible measures of what successful aging is, and hopefully we can come up with these components of that. And I think from this meeting, we've come up with certain things, and we might need to have another workshop to really understand and come up with a set of markers that would help us in achieving those goals. So with that, I'd like to open the meeting for questions from the audience, and also from the panel members, from each other, if you have any questions or any other thoughts that you might have.
I have a question for Eve. When I look at all the information that's being generated by your organization, what's the amount of adoption? What's the amount of use? Portion of the public that actually uses that material?
So if before asking question, if you would introduce yourself, that would be great for the purpose of the taping.
So Eve Essery-Studi with USDA Center for Nutrition Policy and Promotion. And I'll say my side of the shop does a lot of the creation of the recommendations, and my other side of the shop does my plate. And so I'm going to ask our director to kind of speak to this kind of larger implementation piece.
Tag, I'm it. Frank, great question, and it's one that we struggle with. I'm Angie Tag, I'm the Executive Director of CNPP at USDA. And when we talk about operationalization and application of the guidelines, first of all, our mandate is that it gets applied across the federal family. So any of the federal agencies that implement a food or nutrition program are supposed to apply the guidelines. And so when we look at impact of guidelines, we really need to look at it from what's within the federal family as far as an application standpoint, and the number of individuals and families and communities who are impacted by federal programs. We also know that we rely on a whole bunch of practitioners and other policymakers to apply the guidelines in various programs, policies, and other applications. And so that's a little bit more difficult to measure. What we want to be cautious about is drawing a direct connection between the dietary guidelines and overall health of the population. As we've already stated, we have numerous confounding variables that impact that, of course, and diet being one of those instrumental variables. And so when it comes to operationalization and application of the guidelines, one of the things that we're doing in our shop is looking beyond the direct individual intervention. And believe me, I've been taking lots of notes about the individual intervention comments that have been made. We really need to be looking at not only individual approaches, but looking at more of a systematic approach across the sectors, the socio-ecological model being a stepping stone to lead us into that, and really calling everybody to the table.
So one way that might be helpful to get that information, if with your website, would you have how many people have actually come and utilized the MyPlate? Is that information that you would have that could be utilized in that way?
Yes, so when it comes to perhaps even looking at a logic model approach to the dietary guidelines and our subsequent translation of the guidelines into usable consumer messages using choosemyplate.gov, the process outputs that we can easily measure is a wide array of web analytics. And just to give you a snapshot of some of those, we use an online interactive tool called Super Tracker to actually put the guidelines into work for individuals to help them meet their individual healthy eating and physical activity goals. And as of this past week, we have almost 7.4 million registered users. So we are having an impact that way. As a relatively small agency, it's difficult for our agency to reach the 321 million people in this country. Therefore, even more important to rely on other federal agencies and other intermediaries to apply the guidelines. But we have a whole host of other web analytics that we use, and we can track our reach using those mechanisms.
Thank you.
Wendy Johnson Askew with Gerber. I have a couple of comments. I want to pick up on Frank's comment about behavior. That even in the context of the ecological model, the socio-ecological model, you still have that individual at the center. And so you still have to drive that behavior. So I think, you know, I've always had this idea that we would come up with this behavioral phenotype, just like we do for other things, like other physiological phenotypes, to understand that intersection. So I challenge us as scientists to start, especially those of us who delve in behavior, to think about how we can get our hands around the behavioral proclivities of folks so that we can tailor our interventions, our individualized interventions to their needs and not to necessarily what we think should be. So that's number one. The second thing is I want to challenge the dietary guideline process just a bit because, and I've worked on them before in a past life, I know how difficult it is, but when you think about they were intended for healthy individuals and our population is not healthy, we really need to start to think about that paradigm. So if that's looking at a aged population and trying to include that, or looking at children and understanding what those limitations are, I think we have to start to think broader about how we translate that message for folks where they are, not where we think they should be.
So let me be the devil's advocate. I mean, so when we talk about behavioral changes, I think in this case, our first task is to try to understand what it is that we want to change. And I don't think that we exactly know what it is that we want to change in terms of successful aging. And I mean, I totally agree with you that behavioral understanding how we can change behavior is going to go a long way in terms of implementing nutritional recommendations. But in terms of first understanding what is successful aging, that's where we need to be focusing on and understanding the parameters of that, and then coming up with interventions and then the behavioral determinants of that.
And I think it's a broader discussion of how do we change behavior, and then we can pull all these other pillars underneath it. So probably that's my public health background coming out. But you know, I really think that there needs to be a whole segment of science dedicated to understanding behavioral phenotyping. So, you know, we have problems in drug adherence. I mean, what are some of the learnings we can get from that to apply it to nutrition? So there is an active science, and I just think we need to capitalize on it. Thank you.
So Sharon Donovan, University of Illinois, and just a couple thoughts. I was really struck by the demographics. And if we are not doing something, this country is going to be in for a world of hurt. But I look at that as an opportunity for research, and I think what we've seen in the last 20 years is a disinvestment of NIH in nutrition research. And so I was on the B24, and our job was to generate the research questions. there's hardly any research in that age group, and I'm sure if we look at the elderly, it's exactly the same thing. I'm also on the Food Nutrition Board, and most of the DRIs have not been reevaluated since they were issued. And so we have the supplement industry, and we have others who are saying 98% of the elderly are not meeting this. It's like, well, how do we know? We are extrapolating, as Janet said, from younger populations. I mean, we can assume maybe they're vitamin D and folate, but we don't know. So I really think that part of this write-up should say, why do we have a cancer moonshot and we don't have a baby boomer moonshot? Because we have an opportunity to enroll a huge cohort of right now that is slowly, I'm at the tail end of the baby boomers, but, to try to get the mid-50s to enroll, like we have the physicians study and the nurses study. We need these long-term studies, which could involve supplementation, which could involve, lifestyle interventions, and using the appropriate. I was really struck by your data. Is like, we have so medicalized aging that, also the comment about the G-tube. So if they got a G-tube, they're probably sitting in their room watching TV. They're not coming to the cafeteria interacting. And so I really like the comment of taking a very holistic view. Janet brought it up. And but man, we're just like missing this huge opportunity. And maybe since we have a 70-year-old and a 68-year-old presidential candidate, we'll get some traction because they're going to see, as opposed to Obama, who was, 50, late 40s. And so, I think this has to be a really strong message that we do not have the evidence base, and we need to develop that evidence base with the appropriate outcomes that are going to have an impact. And behavior change is important, but adults as learners are very different, and the older you are, the harder it is to change your behavior. And I was taught as adults as learners, you have to access existing file folders. It's much harder for them to develop. So, we need to think about education as well. I mean, maybe I'm thinking I should go into geriatrics instead of pediatrics at this point, but, I think I'm excited about the opportunity, and I'm frightened by if we don't do something now.
Yeah, no, I totally agree with you. At the time that when you look at all the statistics, the funding for example, National Institute of Aging has not really gone up. And I think David and Marianne would agree with me that it's been really disastrous in terms of funding for research. I mean, USDA funding, for example, in that area also has not gone up at all. I mean, and we are, if we don't do anything about this, not to sort of paint a doom and gloomsday, but it's a real problem. It's going to have impact not just in this country, but all around the world, because everywhere else people are also getting older. And I think we don't really understand a lot about the needs of the older adults. I can tell you one example, and that's that, I was very surprised. I mean, a lot of information we have about nutritional status of older people is through their dietary intake, and that does not necessarily reflect what's going on in their body. I mean, if you look at, for example, when I was looking at nutrients that are low based on the dietary intake, zinc might not come up, but I know from our own studies that 20 to 30% of older adults have lower serum zinc level, and that could have health consequences. We don't really know enough, and we need to do a lot more in terms of research, and unfortunately the funding for it has not been there. People are not really thinking in the right way. Does anyone wants to make other comments about or responses to Sharon's?
Sharon, I took notes. Yeah, baby boomer moonshot. We really need to think really big. When I look at the fascinating longitudinal studies that have been done, where we now have these wonderful studies that have 10, 20, 30 years of data. I mean, we really need to think of what are the answers we need for the questions we've raised. How are we going to get them? And they're going to involve these long-term studies, 10, 20, 30 years, to figure out, how is the aging process playing out in our current environment, very broadly defined, and what are those targets we're looking for successful aging.
Johanna.
Thank you, Samin. I just wanted to thank everybody who's participated over the last couple of days, and mention also there's some wonderful resources that the National Academy has put together over the past 25 years. There are many reports on aging. The Second 50 report, which was done almost 20 years ago, focused on disability and the whole issue of some of these things that aren't necessarily the usual biomarkers that have come up in this meeting. But I want to relate one final thing that really has bothered me enormously. Last week I went back to Boston and opened my mail and found long-term care insurance. You know, I have a long-term care policy. The premiums went up from this year, $375 a quarter to $1,400 a quarter, with an announcement that that increase would be followed the next year at least by a 15% increase, okay? The problem is I can pay it, and I did pay it, but there are many people who won't be able to pay it. And so all of this is going to come back on the public purse to deal with all of these people in long-term care. There's a tsunami coming of people over 85, and I'm not sure we can deal with that with the kinds of things we've been talking about right now. We're going to have to go farther than that, and I'd like to ask the panel to comment about that.
Well, this is only a temporary problem. By 2064, all the baby boomers will be dead. So it's just hang in there for young folks. Yeah,
But there'll be others that
will
will
be
replace
dead. All of us baby boomers. No, I mean these are huge societal issues that we keep kicking the can down the road. And by 2030, they're going to be in our face every day. I like to give this analogy. You take a look at Florida, and people have been to Florida, right? A lot of old people in Florida? Yeah. So 18% of the population of Florida is 65 years of age or older. And by 2030, the entire country, it's going to be 20% of the population is going to be 65 or older. So the entire country is going to look like Florida. And that's...
Well, no escaping there. They're going to go
I know
up
you're
too.
going for other reasons to Canada, but in fact, the next decade is really where we're going to have to put the rubber to the road. And it's interesting. Simeon talks about the NIA budget being flat. Actually, it turns out they got this big windfall, but it's all for Alzheimer's. But in fact, what we hear is that everybody's saying, you know, times are tight. I've been hearing times are tight for the last 30 years. But some choices are going to have to be made. And what's going to happen is the hand is going to be forced to make the choices to start addressing these problems in real time over the next decade or so, because the baby boomers are going to be really driving that. So you know, hang in there for a little bit, but work hard.
And the conversations really are starting around this. There's federal conversations, there's state conversations, there's local conversations. So if you want to get the conversation started in your own state, send your governor to something like the National Governors Association. This happened in Georgia in the early 2000s. That governor came back scared to death. How was Georgia going to possibly pay for all these older people? And we had a little flush of money come into our what we call home and community-based services. So what that is part of the federal and state and local conversation of rebalancing long-term care. So, Joanna, we're trying to keep people out of the costly nursing home, rebalancing money going there to figure out how can we keep people in their home, most of whom that's where they want to be, with the flexibility to manage their health and other things in the way that's most meaningful for them. So rebalancing long-term care. Talk about that in your communities and figure out, you know, what is going on, because that's going to be a big part of the solution. And my work locally as a nutrition service provider, and a big part of that is foods and meals. And we have a lot of conversations about what kinds of foods and what kind of meals do people want, and what will keep them healthy, and how to make that one and the same meal So really important things are happening in your own community around these issues.
So we are almost we have about 6 minutes of our time left. So what I like to do to get back to the purpose of this panel and ask each of you to spend maybe 1 minute to say whether you feel we have markers, or are there any specific markers for healthy aging that you think can be utilized? And if not, also, what is the next step that we need to be taking in order to come up with putting together a set of markers or for that purpose? And I'll start with David.
I would put this into two categories. I would, maybe three, but one category are those that are existing now. And there are a lot of good markers of health and a lot of good markers of aging and the intersection of the two. And I think we should take as much utilization of that as possible. The second are new markers. And some of these new markers, a lot of them will be physiologic, biologic, psychological, and I think there are always good research to try to move that along. So the markers of the future, and then the third are the markers that are individualized, the patient preference, the personalization, the saying, what is healthy, what is my healthy aging, what is the aging that I want. So I think that there are the existent markers, the soon-to-be developed markers, and then the personalized markers.
Okay, thank you. Janet?
I think it's important that you start thinking about some markers that are early determinants of an inappropriate aging process. I didn't hear too much about that here, but we did talk a lot about inflammation as possibly being one of the early determinants of an inappropriate process. So some more work in that area, I think, would be very, very useful. And I would like to encourage the organizers of this meeting to build on the momentum that I feel has been created during the meeting to begin addressing the nutritional and other needs of the aging population, to ask the Food and Nutrition Board to maybe take this on as a project and begin developing some standards for nutrient intake as well as healthy aging markers.
Yes, we do have markers for healthy aging and more in the pipeline. And I think we have enough information to identify those that are relevant to people, what's important to individuals, what's important to programs. I do work in health promotion at the community level, so what do my funders want to know, what endpoints are they looking at, and then also to other payers beyond the social service network that I typically work in. Also, I think we need to learn from our public health approaches. Wendy, you brought that up. I call it my special assignment in gerontology in the College of Public Health. So I'm learning a lot more about gerontology. I'm learning a lot more about public health. And they are just way beyond that. You can just influence so many more people by thinking from a public health approach, not at all to diminish how we also need to work with people as individuals, but thinking about what can make the biggest impact from a public health point of view.
I will be very succinct. I think that a marker of successful aging is being proud of how old you are. And if you're proud that you're that age and you think that that's good, that's, to me, successful.
So thank you very much, and I just want to end by saying that I do agree with what was said in terms of we do have certain markers that can be utilized, and perhaps we need to be evaluating them and understanding what the gaps are in terms of finalizing and coming up with a set of markers, and then using interventions to see whether in fact they are useful. So with that, I want to thank all the panel members for their contribution. And turn it to
Thank you very much, Samin. Thank you to all the panelists here, and a tremendous thanks to all of the moderators, the presenters, everybody who attended yesterday and today, either in person or on the webcast. You really did a terrific job, both in terms of engagement and in terms of, I think, seeding some ideas and a real sense of momentum, as has been said, in terms of what might be done moving ahead. And given the fact that this was a really hard session to plan, given the complexity that you've heard about, I want to again call out the Planning Committee for their tremendous work on this. The chair is Pam Stark-Reed. Also involved were Catherine Quick-Uribe, Sharon Ross, Regina Tan, Connie Weaver, Gordon Jensen, and Mary Story. So again, a thanks to them as well. And now, knowing that next steps are going to be important, the slides will be posted to the website with permission from the presenters, and an archive of the video will also be posted online. So if you missed any part of it, particularly those on the webcast, you will be able to get this after the fact. There will also be a brief proceedings of the workshop available in about a month, and a full written proceedings will be published in it says early 16, but I think it's early 17 on the script here. And then again, we want to thank everybody, so a final round of applause. And then for those who are presenters or moderators, there are box lunches. Feel free to grab yourself a box lunch in the West Court, come back to the lecture room, or relax elsewhere. And Food Forum, you're not off the hook yet. We are having a business meeting in the West Court with the lunches there as well, so we'll be convening in just a few minutes. Thank you to everybody, and thank you to the staff. As always, a terrific job.